Luciana. Hi,
Okay,
how
well,
are you guys?
that's why. So let's just do one more
Saturation.
session.
Lee, Gianfranco, Luciana.
Hello, everybody.
Hello. We can see you well and hear you well.
Thank you.
Good.
Where's the review?
So, great pleasure to have Lee here on the table and Luciane.
Okay.
And Javi for the Echo and Ahi performing Echo pictures, very nice Echo pictures. Luca will introduce the case, Miriam, and Davide, technician of radiology, and Anna as anesthesiologist, and Claudio, Lina, and Giovanna as nurse. So please, Luca, introduce the case.
This is the case with young boy, he's 10-year-old.
Well, just wait, we cannot hear.
Non possono sentire.
Sorry. This is a case of a young boy, about 10-year-old. This is a neutral diagnosis of pulmonary atresia with intact ventricular septum. He's at 2 days of flight, underwent to percutaneous intervention with radiofrequency perforation of pulmonary valve and pulmonary plastic valve balloon. In the 3 weeks of surgical palliation with modified right BT shunt. The good increase of the baby, and during the follow-up, this is a good increase of right ventricle sides, and this is a good pulmonary flow. Now the baby, this is a three-party right ventricle with the normal systolic functions, moderate pulmonary valve incompetence, and moderate dilatation of right ventricle. There is the presence of ISD with the right biventricular bidirectional shunt. The intent procedure to evaluate hemodynamic assessment, and is possible to close ISD.
Okay, thank you, Luca. We would like to have also point of view of people working on echo about tricuspid dimensions and right ventricular. You may see here the echo probably.
So
Yeah, perfect. You may see the echo.
okay. So
okay,
we took some preliminary study, and you can see the 4-chamber view, and we looked predominantly to take a look at the right ventricle. Right ventricle looks apex forming, and the tricuspid valve looks pretty normal size, and we measure it. Gianfranco and Lee asked us to take a look quickly at the ASD, so we look at that, we'll come back to that. Predominantly left to right child on this level in the bicaval, but when we applied pulse Doppler, we see definitely bidirectional shunting. Tricuspid valve dimension were 2.71, and mitral was 2.63. No tricuspid valve insufficiency, no mitral valve insufficiency, good right ventricular function. Left ventricular outflow tract looks completely fine. Go back to the tricuspid valve in a couple of images, and to the atrial septal defect. Again, we see predominantly left to right shunt. Pulse Doppler showed bidirectional, as well as color a little bit later. We did some 3D in order to assess the ASD, and I think we have a little bit better. Color again says the bidirectional, and here we can see the atrial septum and the atrial septal defect en face and from different views, as we can see here. Okay. Right ventricular outflow tract, widely patent with at least moderate pulmonary valve regurgitation. And there's just 3D of the aortic valve and the right ventricular outflow tract. So the aortic valve is in the center, and pulmonary valve is more anterior. Again, right ventricular outflow tract. Okay. Then you put the balloon. You want to talk about the balloon?
Yeah.
Okay.
Can you hear me?
Yes, go ahead.
Hi. So this is
not an uncommon problem that we frequently see in the catheter laboratory is the assessment of the adequacy of the right ventricle in somebody who's had a hypoplastic right ventricular syndrome, if you will. So he's had a terrific neonatal intervention, essentially no outflow tract gradient, and because of the, I assume, the regurgitation over the years, his right ventricle has grown. And Aki highlighted all of the points that you need to do when you assess the patient: the size of the tricuspid valve annulus, or the Z-score, the size of the right ventricle, whether it's apex forming, and the function of the tricuspid valve, and the Doppler waveform to make sure that there's no obstruction. So what Gianfranco and I did was approach the case like a Fontan fenestration closure. So we want to make sure that when you close the ASD in somebody who has a bidirectional shunt, when you close the ASD, that he doesn't develop right atrial hypertension. So we did a right and left heart study. We then crossed the atrial septal defect, put a sizing balloon in, inflated the sizing balloon until there was no flow on color Doppler, and then waited 5 minutes, repeated the hemodynamics and the saturations. So he's had an RV pressure that was about 40. At the time, his aortic pressure was 114. His left atrial saturation was 92. His pulmonary vein saturation was 100, and his mid-right atrial saturation was 92, and SVC sat 80. So, and a mean right atrial pressure was 15. So what we did was we balloon occluded it. Can you show the image on the TV set or on the monitor?
Yeah.
Which shows the balloon and the position of the catheter in the right atrium. And after 5 minutes, there was essentially no change in the...
We may give a look also at pressures, please.
Essentially no change in the mean right atrial pressure.
Mm-hmm.
So we think that this is very adequate to close the defect. It was very interesting, as Aki mentioned, it sort of looked like a PFO with a thin floppy septum, but we've sized this using a stop flow technique at about 20 millimeters. So we're going to use a 20 millimeter ASD device to close the defect.
Lee and Gianfranco, did you guys consider doing RV angio, not only to assess RV size, because I think this was pretty straightforward on echo, but mainly to take a look at the pulmonary arteries. This kid had a BT shunt, which has a tiny little residual shunt. Sometimes, there is some tenting of the pulmonary arteries, and you might have to put a little stent or something. Do you think this is a good idea?
Well, I think doing angiography is not inappropriate to assess the anatomy. If there was any questions on transthoracic echo, I think that in some units what we might have done pre-catheterization is to do an MRI to look at the flow dynamics and the anatomy. But his main pulmonary artery pressure was peak, I think, 35, and we did an aortogram to take a look at the flow to see if the BT shunt was still patent, which it's not. But we can do a P. I don't think that's incorrect or unnecessary.
We may go with that in the and then exchange with the pigtail.
Can we show the balloon with the?
Aki wants to show the balloon across the septum, which I think is not unusual.
So we've been prepared for angio. We can see very nicely the balloon to dimension obstructing practically the atrial septal defect, and color show there is no residual shunt across, and we were able to get also to show that the balloon practically is completely covering the atrial septal defect. We don't see the big void of tissue there, and we looked at both sides, and you can see the edges of the balloon itself, and the ASD is not there. And you can see both simultaneously 2D and 3D balloon size, and we measured the waist again right there. It was about 1.5 centimeter, and practically there is no flow. We also after, I think you occluded the ISD for about 10 minutes, something like that, we look at the inflow and to be sure that there is, first of all, no tricuspid insufficiency on one hand side, and to see the inflow and to be sure that the diastolic function, at least the E to A ratio, are within normal range and nothing changed significantly. So that's all. Yes.
Whose idea was it
It
to do
seems
this?
to me
idea?
there is a prominent
Carlos.
A wave there. And we see that the A wave is not that tall before occlusion. Once you occlude the hole with the balloon, when you do the test occlusion, this becomes more prominent. Have you seen that before? What is Lee's impression and Gianfranco?
No, I
Because
think
of restrictive RV physiology, which is good for PR.
I think you're absolutely right, and we have seen this in patients with long-standing tetralogy of Fallot and significant PR, as well as older patients with ASD with dilated right side of the heart. And it's interesting to see how quickly it's really normalizing. The youngest the patient and the shorter time that the heart is under volume or pressure overload, the quicker it returns to a normal pattern. But this was practically exactly the pattern before we started. So it will be interesting to see what's going to happen and how quickly he'll return to normal Doppler, normal diastolic function.
Okay.
So you guys have two venous axes, is that right? One for
Yes.
the balloon, the other one for pressures and now pictures.
That's right. You could, we used two separate veins. You could have double perked one of the veins. We didn't perclose it, either vein. But we figured that it's a low profile delivery catheter.
Lanjo. May we put a balloon across the defect? What do you think?
You want the probe out?
With the angio, just to be sure that there are
Any
no other
questions from the
accessory
audience?
holes. Okay.
It's getting bigger and bigger all the
Yeah.
time.
Yeah.
Let's go do a 2D.
Okay, ready to inject?
Just a moment.
Almost ready.
We're going to have that white out.
Is the probe out of your field?
Now you can pull it back just a little bit. If you
Okay,
want.
I don't need it right now.
You want to test it?
Test?
You better pull it up a little higher. It's be right over the
Okay.
RPA.
I'm check. Okay.
Should we go?
Yeah.
Okay, ready for angio? Okay.
Okay, so there's, on levo phase, there's no shunting from left to right, so we're completely excluding the hull. And certainly the left pulmonary looks good, and I think that the proximal right looks pretty well, and I don't see any obvious narrowing. So I think that we're okay there.
Do you think there's a bit of distal stenosis in the right and that there is preferential flow to the left?
Well,
PA?
we're injecting in the left PA.
Do you wish another angio from? Do you wish another angio in RAO with the catheter more in the right?
Yeah, okay.
Just just a peek. Okay.
It's pretty good, huh?
Okay, if you come back, it should go with the wire. Okay, and that.
You got the wire?
Okay. Ok. Facciamo 20.
There's a question. Go ahead.
getting there.
Identify yourself, please.
Sorry.
It's okay.
It's the danger of being an interventional echocardiographer.
Great, thanks. Gareth Morgan from London. Could I just ask, this kid's under general anaesthetic.
Yeah.
The hemodynamics look good under general anaesthetic with the balloon across.
Yeah.
A couple of questions. Do you have any way of assessing how well this child's going to perform awake, running around? And as a follow-on to that, is there any benefit for considering a fenestrated device when you're closing this hole?
Could you just pull the echo probe back?
A bit more central or not?
I don't think he was listening.
No, I was listening to you. I always listen to you, Gareth, like I did when you were a fellow.
Okay.
Okay, let's do the angiogram and then I'll address that. Ready?
Yep.
Okay. So there's a little stenosis here. Maybe we'll do a pressure pullback and see what it is.
Guida da cambio e il multipurpose. Sì, sì.
Well, we could do it with this.
Pull back. There are a lot of holes everywhere. We may change with the multipurpose.
So your question, Gareth, was about whether you would do a fenestrated closure.
Yeah, or whether you can objectively assess how he's going to perform awake and exercising.
I think experience would tell with these kinds of hemodynamics that this child is going to do very well with this ASD closed, and that, you know, you just get into make it more complicated by fenestrating a defect. Then you have to go back and close it. I think he'll do just fine from the hemodynamics. You make these kinds of decisions in fenestrated Fontans the same way. You know, with this kind of a result, you certainly would think that the hemodynamics would be acceptable for a fenestrated Fontan closure.
Thanks.
What would make you think that it would need to have a fenestration?
I don't know. I mean, the fact the kid's desaturated, I don't know.
Well, it was
very
92.
much a very open question.
I mean, I think your point is well taken. You're always concerned about those kinds of things. He's not a Fontan, so the flow physiology is a little bit different. But the yeah, we're just moving the catheter into the RPA. The flow physiology is a little bit different, but we don't. With these kinds of results, we wouldn't close the fenestration. We wouldn't close the fenestration and leave a fenestration in a Fontan.
Just a quick comment. Lee, I'm with you on this. I think the more tests you do for a relatively simple lesion, the more confused you get. And doing a cardiopulmonary exercise test in this patient with an ASD still open, the likelihood is that there will be right and left shunting at some sort of peak exercise. So you're not going to be any the wiser after a cardiopulmonary exercise test, and it's not going to help you make a decision about fenestrating the device. So I would just go ahead and close it.
Okay, so his distal RPA pressure is 23 over 15.
Okay,
and
they see the pressure.
Okay, we're just, so that, I'm pretty
Lee, somebody keeps, Chetan Mehta from Birmingham keeps telling me that your ET tube is too far down the right lung.
Go ahead, Felix.
Well, Lee, the only question we
Yeah.
originally have in this case is whether the restriction in the pulmonary vascular system or the restriction of the RV will be a problem with closing the hole. So I miss the change of the diastolic blood pressure in the pulmonary artery or the change of the right atrial pressure during occlusion of the defect. That's the only thing what we should know. I think we do not need any angiography to test whether it is residual shunt in the left atrial level, because this is something what we can reveal with the echo. So the only thing what we should test, and this is with the disagreement to shock, is whether the restriction in the pulmonary artery vascular system or the restriction the ventricular function will give us a problem in further course of this patient.
Okay. ACT
So
is
Gianfranco and
260.
Lee,
Yeah.
what are the plans now? Are you
260.
planning to tackle these distal RPA stenosis before closing
Yeah, Carlos.
the
Yeah, we are performing a pullback pressure gradient. If we may have both angio and the screen with pressures.
Yeah, so that's the proximal pressure, peak of 26,
Can we see? Yeah, the monitor.
and that's the distal pressure. And this
Is it
is
necessary to keep the balloon up to do that? Because it seems to me it's close to the IVC and blocking cardiac output.
Yep.
sure.
You are very demanding, Carlos.
Yes,
huh?
you're making this.
sorry.
You're making this
There's another
very
question.
complicated case.
Not a question, just command.
You know,
I would pull back the tracheal tube a little bit because it's sitting in the right bronchi.
yeah, it does look like it's sitting in the right bronchus a little bit.
Mm-hmm. Okay, so let's pull back the balloon. I pull back the balloon.
Okay.
Okay, so balloon is now deflated, and we may check again pressures. We have 18, 25 over 11, 12, and 18 the mean.
That's distal,
That's distal, yeah.
and this is coming back just proximal to the stent, the stenosis. The waveform does change, but it's 25 over 12. (26)
27. Distal, okay.
Yeah, to be absolutely honest with you, I don't think I would do anything to this stenosis. You put a stent in, you're going to have to bring them back, put another, redilate it. I don't think there's a hemodynamic cause. I think that if it turns out in the years to come that you do a perfusion scan, or you do, well, maybe not a perfusion scan, or an MRI, then if there's an important discrepancy, then you could deal with it. But I don't think that, I think that the major problem right now to address was the hemodynamic assessment and close the ASD and then see what happens thereafter.
Okay.
I mean, would that be?
Yeah, I agree with Lee, absolutely. Anyway, we would have to redilate in 3 years' time, 4 years' time,
Yeah.
so we will do follow-up and shall see.
Okay, so we're going to
Perfect.
change this over and close an ASD.
Lee, you've closed a couple of those defects in patients with borderline right ventricles. You published a paper a couple of years ago.
Yes.
And in our experience, these ASDs, you might start with some holes on the smaller side, such as this one, 8 to 10. And after balloon interrogation of the septum, you end up with larger holes, such as this one, 18 to 20. Is this your experience, like stretching the septum primum, which sort of leads you to a choice of a larger device with a larger RV to prevent right to left shunt?
Well,
e teniamo qui 20 da dia. Sì.
Millimeter, and the waist of the balloon is about 17. And I think Lee said that you're going to go with the 20, right?
It was 20 on the...
Okay, so I think that will address that. And I don't think in this case we're really dealing with a borderline right ventricle. I think this right ventricle is good.
No, I agree. It's just how the septum behaves in those patients. How the interatrial septum, you can straight it up to whatever. I mean, usually it's more than a regular ASD.
I think we took into consideration there is some component of the atrial septum that it's more floppy than 30. So I think to go with 20 or beyond, I think
anyway,
that's the right
we have
thing.
a waist on the balloon.
How much?
1974.
Yeah, the other thing, I mean, the transthoracic looked like a PFO, but that portion of the septum very thin and very floppy. So I'm not surprised that we talked about it. We thought it would stretch up considerably more. It's sort of like some of those PFOs you see that have a long tunnel that for some unknown reason you balloon size it and it becomes not a PFO anymore in your mind, and you end up putting an ASD device in when it really just needs a PFO device. You know, you sort of get into that trap. I think here we anticipated, because it was a very thin septum prominent portion of that atrial wall.
Carlos, can I make a comment?
Yeah, Bharat, go ahead.
French and 20.
Yeah, no, I think that this is one subset where there is a real risk of undersizing the defect, at least in our experience. As a matter of fact, we have embolized one device by undersizing the size of the defect. And this is one condition where we would balloon size, although normally we don't, for deciding what size of device you should use. And you will be surprised many times it almost doubles what you see on a routine transesophageal echo. So I think what they are probably using is the appropriate size device. That's what I feel.
Thanks, Bharat. So how big a device are you guys using?
It's going to be a 20.
20.
We can try to see
Okay.
the device in
Sì.
3D.
Yeah. Sure.
So we're just getting it ready.
Sì.
So for all of you who have not ever seen an ASD closed,
while you do that, let me interrogate here a quick show of hands. Who would follow those patients with exercise tests? Please raise your hand. Wow, almost nobody. Okay. Who would tackle the pulmonary artery right now at this procedure? Okay, minority of the audience. So that's good. Seems that everybody's supporting the decision.
yeah, I think that doing a cardiopulmonary exercise test is good. I like those tests. They're very insightful, particularly if, you know, patients who've had this kind of anatomy in the future. Let me just get a dry glass. Okay.
Okay. Can do it for you.
I'm going to take this out because
No, we don't need that anymore. Probably in the right atrium, no? Do you need to open the skin a bit more?
Yeah.
No, it's okay?
No, no. Gianfranco didn't make a big enough incision. Okay. So, I don't know how you folks do this, but this is a trick that Francois Pierre-Chard told me, how he closed it years ago to avoid getting air into the sheath. And that is not to put the dilator into the left atrium, but just put the sheath up over the wire and then take the wire down and take the wire out and make sure that you get blood back as it comes out by holding the catheter below the level of the atrium. There's the blood coming back. And then you know that there's not going to be any air in the sheath, which was a big problem years and years ago when we were starting to do these things.
flash. Yes.
Okay. All right. Nice and tight.
What I usually do to the air is to advance the introducer over the dilator, over the wire, up to the pulmonary vein, so the flow coming from the pulmonary vein.
That's another one.
Right.
That's another one.
Yeah.
That's very good. Okay.
Okay.
So we come up, pull it back, make sure that it's attached still. All right. I don't know, I haven't done this in such a long time. The fellows usually do these cases. Are you watching the echo? Okay.
Can we see echo and fluoroscopy, not your hands? Oh, just
Wait
wait.
a bit, just to show the echo.
We didn't see echo. There you go. We're
What?
too fast, Lee.
Well, I don't know.
Okay, can you make echo bigger? Achi, what's your impression?
It looks like, you know, we look at both legs. It looks like it's practically straddling this aortic rim. Looks very nice here. We'll put some color, see if there is any residual. I think these little speckles are in with the mesh of the device itself. We'll take a look at the bicaval view right now. Sitting very nicely. Looks like it sits very nicely and there is no residual shunt there.
Oxygen
it's far from the tricuspid valve.
And pressure is
far from the mitral. So
and aortic pressure.
It looks good. Let's do some 3D here. And
lavare. Seconda linea. Seconda linea. Okay, any comment from the audience?
So what about the stacks and RA pressure?
Yeah, there's no change in RA pressure. The saturation is 95, 96. The aortic pressure is the same. So hemodynamically, it looks very good.
I like this one.
So
you guys are done.
I like to do a little wiggle there. I also like to look at it in a different projection. Aki,
yes.
Just watch your shoulder, because I'm coming in this direction. Just for a second.
Yep.
Yeah. So this is sort of the projection that I like to see. Can you just pull the probe up just a centimeter or 2 centimeters, just a little bit?
It'll be how much?
So in this projection,
I have to take the probe out.
I always like to see the LA disc have a nice curve to it. It sort of reinforces the fact that there's no prolapse of the disc into the right atrium. So I expect to see certain things in certain projections when we do these kinds of studies. So I always like to do this in the 30-30 because I know what the device is supposed to look like. So that's, and the other thing is I always bring the sheath back so that it doesn't.
We may do a proper angio.
Okay. Angio.
No, I do by hand. I do by hand.
I also like to bring the sheath back after I release the device, the right atrial disc, because the stiff cable deforms the device just a little bit. So that sort of lets it take a bit of a a more anatomic position. So that's why it's way back there.
And also by this angel, you may clearly see the septum in between the two discs of the unplugged occluder.
And there's a little shunting, but that'll go away.
Okay.
So we'll do one more thing.
3 minutes, too.
We just a little bit of that.
Come back for the talks and then
that looks good.
You're pushing it.
Yeah.
Okay.
Okay.
Go ahead.
Go ahead. It's all yours.
Yep.
Okay.
Here we go. Voila.
Bravo.
Yep. So we don't see any residual.
Can you make the echo bigger? Perfect.
Looks great. This is bicaval, and we'll go back to the.
Speak loud, Ari.
I'm saying that both in the bicaval view and the longitudinal, it's really engulfing very nicely the aorta with no residual shunt on the superior or inferior rims and the aortic rim. So we are happy.
Great. Looks like you had great results. 1 minute for the final comments, Gianfranco and Lee and Luciana.
Yeah, please go ahead with your questions.
Well, you guys are a tough crowd to please. Okay. Well,
Okay,
we think he's going to do very well. Thanks very much.
Thanks a lot.
Much.
Bye.
Bye-bye.
So let's come back to the talk.
Yes, we think we have to proceed with the fetal talks, and we will like to invite Dr. Roland Gitter from Linz University to speak about the pulmonary valve procedures in